that we're missing the point, that testosterone is not the enemy. In fact, aggressive suppression of testosterone has been shown to cause a phenomenon called transdifferentiation. That's when the cell type of the testosterone mutates into a more aggressive, untreatable form. It goes from adenocarcinoma to neuroendocrine carcinoma, untreatable. So you want to be thoughtful about how you're going to be shepherding your own health care. Dogma always gets in the way of thinking. When there is a protocol, a dogmatic approach to something, a consensus, it kind of is a shorthand. We don't have to think too hard. We've already given it thought. Therefore, we're going to jump right into the pathway. And I'm talking now about prostate cancer diagnosis and treatment. I've shared with you my opinion about biopsy. They should never be done. Almost never. No, never, in my opinion. Now, there's a rational basis. No, not even a rational basis. There is a historical and psychological basis for doing it. After all, don't we want to get a tissue diagnosis early? Answer, not really. The question at hand isn't whether or not getting the information early is worth doing. It's, will it help save lives? And there's evidence that sticking needles in the prostate can have the opposite effect. So what are you to do? You have an elevated PSA, you have an abnormal MRI. Well, I'd like to turn the attention today to focusing on those of you who already have spread of cancer. Now, you know from prior studies I've shared with you, the majority of men with indolent cancer cells in the prostate gland, these are atypical dormant cells that are inside the gland that aren't going to harm you as long as they don't leave the capsule. The challenge is keeping them there. So in prior podcasts, I've talked about some of the approaches. My protocol is built around this concept that our body is constantly fighting cancer and keeping it boxed in. But suppose it doesn't stay there. No matter what you do, some of you men are destined to have the cancer progress. And although the majority of men with atypical dormant cells in the gland will take them to their grave, it will still spread and kill some men. So the objective is to not die from prostate cancer. Or, if it's your fate to die from prostate cancer, to delay that moment as long as possible. And yes, always, always, always prioritize vitality. We'll talk about that. There are treatments out there that are guaranteed to cause you harm. Maybe not any benefit, but guaranteed to crush your vitality, to be avoided. So you're listening to me speak, maybe you have bone metastatic disease, or the lymph nodes have spread, or it's extended. And now the doctors are lobbying you for aggressive therapy. We need to do testosterone annihilation therapy. We're going to lower testosterone. There are different ways it can be done. We'll talk about when it should be done. First, never because of what's called a biochemical recurrence. What does that mean? Well, you've had your gland removed or radiation done, all right? You had that done before you had a chance to listen to me. Those of you that know not to go down that pathway because it guarantees harm and it's not been shown to prevent death from prostate cancer, right? Let that sit there for a minute. Guaranteed harm, no benefit regarding avoiding death. Why would you even do it? But for many of you, that bridge has already been crossed. Unfortunately, up to 40% of men who subject themselves or are convinced that they need to have their gland removed, up to 40% of them are going to have a biochemical recurrence. That means the PSA level is starting to rise. The patient feels good. You feel healthy. Doc, I feel great. My energy's great. I'm peeing fine. Nothing's wrong. Yeah, but your PSA went from 1 to 5 to 6. It looks like the cancer's starting to percolate. Let's get you treated. What do? They castrate you. Androgen deprivation therapy. This should not be done just because of a lab value. You are sacrificing vitality for the sake of numeric comfort. Oh, they caught it. My PSA went from 8 to 2. Big freaking deal. What you care about is your vitality and your lifespan. So where does this information emanate from? Well, we know that the PSA does roughly correlate with cancer burden. So there is some merit in monitoring it. But beating it down just because a number went up, there was an important study. It was called the TOAD trial. Trial of Androgen Deprivation Therapy. I swear they come up with the acronym before the study, the TOAD trial. So in this trial, they had two groups of men with biochemical recurrence. In one group, they put them on immediate deprivation therapy. The other group, they delayed it. Up to 2 years. Nothing up to 2 years. And what they found was they had the same mortality outcome. That is, no benefit to starting early. Now, there may be benefit in delaying. When PSA starts to rise, when prostate cancer begins to spread, and if it's in your bone and causing pain, or in organs and causing dysfunction, or blocking urinary flow and causing compromise, then androgen deprivation therapy can be therapeutic when used properly at the right time. It can reverse some of these symptoms. But here's the catch, men. It always ends up failing. Not now and then, not some of the time, not maybe 100%. If you stay on androgen deprivation therapy long enough, the cancer will plow through it. Now, if we know the clock is ticking, it makes sense to delay implementing it as long as possible. Imagine it this way. You're holding a defensive position, the enemy's coming at you, and you've got limited ammunition. The enemy is 2 miles away, you see them, but your ammo only shoots for a mile. So you start firing like crazy because you're nervous. By the time the enemy is within range, you're out of ammo. Like the androgen deprivation therapy, hold it in reserve. Now, what then? The bulk of evidence is starting to sway opinion here from constantly depriving you of androgen, of testosterone, to intermittently treating. So you hit it for a while, get the symptoms under control, PSA goes down, and then you quit. Why? A couple reasons. One, you're going to feel better. Blocking testosterone is bad for your health. It makes you tired. It makes you grumpy. You lose muscle. It increases risk of dementia. It correlates with a bump up in heart disease. So balance. In the face of acute symptom, it makes sense, but go for that intermittent pathway. Give your body a chance to recover and to feel better. Now, what about combining things? So I've had some patients have gone to conventional oncologists who have metastatic prostate cancer, and they'll say, well, we're going to hit it with triple, quadruple drug therapy. There are different kinds of ways to block testosterone. One of them is Lupron. There's a classic drug in this class, Leupride. It's an androgen, it's a pituitary hormone agonist, a luteinizing hormone agonist. And what it does, it exhausts the part of the body that stimulates the development of testosterone to the point where the body doesn't respond and the testosterone drops. Now, these drugs are harsh. They cause a lot of side effects for many men. Another class of drugs are androgen antagonists. Orgovyx, Relugalex is a classic drug in this category, and it blocks production of testosterone. Generally speaking, a little more gentle, less side effect. There's a third class of drug, which is an androgen receptor signaling blocker. This type of drug, Xtandi is the trade name. The generic name for the drug is enzalutamide. This class of drug blocks the testosterone receptor. It's a more thorough way to blunt testosterone. Now, the dogma in most of the urological world is the more we can block testosterone, the better. We're going to do this, triple drug therapy, and we're going to annihilate your testosterone. And it's going to help you live longer. Maybe. Here's a problem with all the studies. And you have to weigh this because, first, there's a publication bias. When a study is sponsored, it's sponsored by drug companies because they want to prove the drug works. So there's a publication bias. There's a tendency not to publish negative outcomes. There's an interpretive bias. The drug companies oftentimes have their people involved in the study. They fund the study in many cases, at least a big chunk of it. They also have some of their people involved in interpreting the results. This does not completely invalidate the study, but it creates an inherent conflict. Now, in medicine, conflicts are unavoidable in many cases. Your job is to be aware that they're out there. And the way they show up is in the interpretive phase. When they summarize the study results, oftentimes there's an interpretive bias. The other problem with the studies, you're not like anybody in that study. Everybody's different. Prostate cancer is varied, and they try their best to try to organize the studies and organize the patients into categories of similarity, but it's impossible. So for instance, one of the studies cited is called the CHAARTED study, capital CHAARTED. And in this study, they hit men with chemotherapy and they hit men with multiple drug treatment. And their conclusion was that this aggressive multi-drug regimen helped people live longer. However, there's a caveat. Only the men with what's called high burden disease appeared to benefit. Now, high burden disease means not local lymph nodes. It doesn't mean you have some in the pelvic bone. It means you have a lot in the bone outside the pelvis and outside the spine. It's in your femur, it's in your arm, it's in your liver. That's high volume. So there's one challenge, how do you interpret the volume of your disease? That's tough because it'll help guide thought about treatment. Other studies have demonstrated something similar. The STAMPEDE trial looked at multi-drug therapy, and they found more aggressive treatment helped men live longer. What was the difference? The multi-drug treatment had 83% survival at 3 years. The single drug arm had 76% at 3 years. Statistically significant, but a small delta, small difference. The PEACE-1 trial in 2022 demonstrated value with multi-drug regimens only in high-volume disease. So there's this challenge. When a study is done, it's usually tightly controlled. In the clinical world, the parameters are wider, and more docs may be inclined to say, well, it probably will help you. We're going to be aggressive. And, in all fairness to them, this disease is going to progress. If you have prostate cancer in the bone, there's no known cure for that. You're dealing with quality of life, survival, extending your lifespan. But unless you die of something else, you're going to die of prostate cancer. So I don't want to be pessimistic, but just let you go into this with your eyes wide open. You get to decide how you want to live. All these drugs harm you. They all make you feel terrible. And in many cases, the extension of life is simply an invitation for extended misery. So you have to be eyes wide open. But back up a step. Going back to 2004, the study that validated chemotherapy can help you live longer. 2004. Now, remember what I said about dogma. When a fact becomes embedded in the mind of doctors, it's tough to shake. Look, a doc who reads a study on Friday that challenges what he or she's been doing their whole life, they're not going to come in the office on Monday and say, guess what? We're changing everything. They hold on to their dogma. So 2004, the TAX trial looked at the chemotherapeutic agent docetaxel. And they looked at men who were on the chemo versus those who were not. We call this beating up a straw man. You're comparing an active treatment to doing nothing. Not hard to really top that, right? Anyhow, in this study, they did conclude that chemotherapy helped men live longer. That's the conclusion. Remember, publication bias. In these studies, they tend to gloss over or minimize quality of life consequence. They'll report them numerically. Well, there was a grade 3, 4, 5 reaction. In some of the studies, those grade 3, 4, and 5 reactions are 60% or more. Now, grade 5 means you're dead or in the hospital. A grade 4, life-altering, hospital-level sepsis, IV antibiotics, blood clots, strokes. A grade 3, permanent life-altering adverse consequence. We're not talking, I feel a little nauseous here. We're talking, holy crap, I wish I never did that treatment. So quality of life you got to consider. Now let's go back to life extension, the tax trial, 2004. Here's the difference. Those that were on chemotherapy, 18.9 months survival. Those who were not, 16.5 months survival. Roughly a little over 2-month differential between chemo and all of its misery, gastric upset, vomiting, hair loss, fatigue, infection, low white counts, versus 2 months. 2 months you get to live with all that? Is that worth it? Maybe it is. My point is not to tell you what you value. It's to give you information, give you options. If you know you're going to eventually die from prostate cancer, in my view, you owe it to yourself, to the people around you, to get honest appraisals about what that life is going to look like. If you're spending 2 months hugging a toilet bowl or going back and forth for yet another clinic visit, why do we do this? Why do we do it? So quality of life, preeminent. Might there be a better way forward? That's the other problem with dogma. There may be a better way forward. It is possible that we're missing the point, that testosterone is not the enemy. In fact, aggressive suppression of testosterone has been shown to cause a phenomenon called transdifferentiation. That's when the cell type of the testosterone mutates into a more aggressive, untreatable form. It goes from adenocarcinoma to neuroendocrine carcinoma, untreatable. So you want to be thoughtful about how you're going to be shepherding your own health care. Bottom line, you got time. You could take a moment. If they're going to do something that's going to obliterate your testosterone, then by all means, take a time out and think about it. I don't think there's any role for chemotherapy, period. Based upon the research that I've done, what I've observed in the clinic, the published studies that are out there, you look at the benefit from adding chemotherapy to these other treatments, it's hard to find any merit. The studies concluded is nearly zero benefit, no extension of life. Why do we do it? Well, it's emotionally hard not to when you're looking at somebody who is facing a mortal disease. The problem, of course, is a treatment is worse than the illness, at least when it comes to chemotherapy and prostate cancer. So let me leave you with a message of hope, guys. I don't care where this cancer is. You have time in front of you. Manage your life positively. Fight cancer like a man. Don't give up your vitality. Cling to the straw that somehow, some way, you're going to have a long and quality lifespan after they crush you with some of these treatments. It's quite possible that your outcome would have been just as good or maybe even better with an alternative approach. And we'll be talking in the future about actually using testosterone to help treat prostate cancer. It's a novel concept that is gaining some traction in the studies. Until then, keep the faith, live strong, live vitally, live like a man. Be yourself. If they're going to compromise your quality of life, you got to know the facts. What's the trade-off? And are there better alternatives? That's what we're here for. All right, till next time, team. We'll see you then.